So I would like to welcome all of you. My name is Bradley Flam. I'm the director of Westchester University's Office of Sustainability, and we are honored to be able to co-present the Sustainability Research and Practice Seminar this semester with our colleagues from the Office for Research and Sponsored Programs and the Office of Digital Learning and Innovation, as well as the Sustainability Council's Scholarly and Creative Activities Committee. We're all very happy to be able to welcome Dr. Sankaran today as the, I believe this is the 6th, this is the halfway mark in our semester. There have been 12 presentations scheduled for the semester, and if you are not familiar with who is on that program, just go to the Office of Sustainability's webpage on the university's website, and you can see the entire schedule for the semester. So without further ado, let me thank Dr. Sankaran and pass the virtual floor to you.
Thank you, Dr. Flam. I want to take this opportunity to thank Dr. Flam, Dr. Bennett, Dr. Kolasinski, and I'm going to say Dr. Maxey and Dr. Herman too, okay, because I'm an optimist. So my optimism has to show in the beginning itself. And all of you for, I know, taking the time, especially it is the lunch hour time to come to this presentation. So I'm going to take time to share my screen. So if I'm quiet for a second, that's what I'm trying to do right now. Okay, are you able to see the screen? Okay, thank you so much. I'm Gopal Sankaran, and I'm in public health. This is my 33rd year at Westchester University, and I have loved every moment of it, except for the COVID-19, I should say, because I want to dedicate this presentation to the millions of people worldwide affected by COVID-19 and those who lost their lives. And I say that because just last Sunday, one of my colleagues from medical school passed away in the United Kingdom. He was an orthopedic surgeon. So it is something which touches all of us in one way or other. And I also want to salute the heroes who have been several in terms of fighting this particular disease in spite of their own issues. They have been doing that, which is phenomenal. So there are three themes which I want to address. They are intersecting themes. One is the UN Sustainable Development Goals, which, as we all know, is slated to be reached by 2030, and they were put in place in 2015. The second one is the COVID-19 pandemic and its impact on SDGs. But I want to give a little bit of background about the COVID-19 because the politics part of it comes from that background. The third one, of course, is to look at our collective future 2021 to 2030. And I want to allay any kind of fears that I'm not Nostradamus, nor am I having any kind of a crystal ball. So it is more of an opinion in terms of what it might occur, and also my longevity in terms of my time in public health. So that's the reason why I take the liberty of talking something about our collective future. So the UN Sustainable Development Goals, you're all familiar with the 17 goals, and all I want to point out is there are 17 goals and there are 169 targets. So there's a lot to track. There's a lot to track, and that tracking itself is quite an effort for many nations. I want to distinguish between the UN Millennium Development Goals and the SDGs for a couple of reasons. The UN Millennium Development Goals preceded the Sustainable Development Goals, and there were 8 of them, and they were for the period from 2000 to 2015. The reason why I want to distinguish here is because the goals were laid out in a different manner, and the goals are going to be encompassing a larger group of nations, in fact, all of us. And those are very critical things when we think about the politics and think about getting a handle on COVID-19, getting a handle in terms of our progress towards the Sustainable Development Goals. So what are some of the key differences in SDGs? There are a number of differences, but I just culled out some of the key ones over here. These are absolute goals. For example, if you look at Millennium Development Goal 1 and Millennium Development Goal 2, it is complete eradication of poverty in the first one, and eradication of hunger. So that is going to be for every person who is on this planet at that point in time in 2030. So that's what we are trying to do. Whereas when you look at the Millennium Development Goals, they were more partial. For example, just to give you an idea about that, is the fourth goal was reduce child mortality. The fifth goal was improve maternal health. So they're very focused ones. These are absolute goals, and that's something that we need to keep in mind. They are more comprehensive in scope because the 17 goals, if you look at it, they all are intertwined. They are not standalone goals. They are intertwined, much more intertwined than what you found in the MDGs. There was an inclusive process, so it wasn't done from the top alone. It was done from both the groundswell, if you will, in terms of the nations putting input into it and the UN providing the leadership for it. It is applicable to all nations. This is a very critical difference between the MDGs and the SDGs. The MDGs were focused mostly on the low-income nations and the middle-income nations, whereas this one is for everyone. And that's an important one, which means when we harness for economic power or looking for leveraging technology, that is going to be useful. It's a different model of funding because in the previous one, the funding was mostly in terms of the donor. So the flow was from the north to the south. Whereas here, what we're looking for is sustainability, economic sustainability as a central focus of these goals. And so that itself will allow for the progress which we make to continue even after 2030. There's a tremendous emphasis on data, and the idea is that we are not going to have any paucity of data because we cannot afford to have it. As I mentioned, we have 169 targets. So what are some of the impact of the pandemic and its COVID-19 pandemic and its impact on SDGs? And as I said, I want to give you a little bit of background information before we dwell directly into the impact. This is the COVID-19 data as of today from the Johns Hopkins University of Medicine Coronavirus Resource Center. And you can see over here, let me get the laser pointer. You can see over here, this is the total number of global cases, which is 117 million. And this is the total number of deaths, which is about the 2.6 million deaths which have occurred. And we are right at the top. We are right at the top in terms of about 29 million cases, and then about a little over 500,000 deaths. And these countries are ranked. And this becomes one of the very critical and useful data sources which we have for. So one challenge which we see is it is a pandemic, we say, but it is not really a homogeneous occurrence of the disease or occurrence of deaths in different places. They are very quite different, and you're going to see that in the next slide. So obviously there are some factors, there are some underlying factors which are necessary for this different distribution in different portions of the world. Even within nations, we find that there are different distributions. So what's some of the reasons for it? One is what you have already heard about a lot in terms of in the popular press too, is the R naught, which is how many other people are going to be infected by one infected person. This is not a great measure, but this is a measure which is often used in infectious disease epidemiology. We have a lot of asymptomatic and mild cases, and now the numbers are hovering somewhere around 30% of the cases. Some places it is even higher than that, about 40 to 45% of the cases are asymptomatic. There's a long incubation period. If you think of certain conditions, like for example, the common cold and others, which have a very short incubation period, this one has got a 14 days incubation period. So there's a greater opportunity for spread of the infection to others. Then we worried a lot about the survival of the virus in the environment, but now we are coming to grips that probably what we are doing in terms of the environmental control, in terms of cleaning up the places or personal hygiene, environmental hygiene together, that doesn't seem to be a major driver in terms of what is occurring with the COVID-19 transmission, as well as the number of cases. This is what I was trying to point out, is that when you see different countries, they all have different type of graphs, different type in terms of the height that is showing how many confirmed new cases have occurred, because you can see that in the y-axis over here, and this is the time period from March to March 20th, 2020 to March 2021, so 1 year of time frame. You see that we are right over here. This is the United States over here. The green one is representing the Brazil. It is showing what is occurring in Brazil. And this blip which you see over here is Turkey. And other than that, you are saying, other than that, it is not very something which is very different in terms of each of these nations showing some of the characteristics which you see in terms of occurrence of disease. So that brings us to the important question. What is the reason for these different trends in different places? One, of course, is the timing, how long the virus has been circulating. If it is circulating for a longer period of time, especially in a susceptible population, which is the population which doesn't have any kind of innate immunity or protection against the disease, it is going to go spread much faster. Pre-existing health conditions, this is very interesting. In fact, United States has the highest pre-existing conditions or comorbidity conditions of all the OECD nations, the Organization for Economic Cooperation and Development. Among all those nations, Western nations, we seem to have the highest pre-existing or comorbid health conditions, whether it is diabetes, whether it's heart disease, whether it is cancer, whether it is other immunocompromising diseases, whether it's COPD, all those conditions, we seem to have a higher proportion. And that is, again, an important factor in terms of the spread of the disease. And the response, what kind of response the nation, what kind of response the community, what kind of response the region, what kind of response within the nation has provided is an important one. And the next 2 or 3 slides are going to focus on that. Because one is the disease research occurring, but what is the action which we are taking is also going to change the trajectory of the disease. Either it's going to keep it at the same ebb, or it's going to increase it, or it is going to decrease it. So there are 4 responses to COVID-19, which are often considered to be the key pillars. And these pillars are not standalone. These pillars are actually holding up our response. So they are together, they are helpful, and they are interwoven. The first one is the surveillance and detection. And there's a little bit more detail in the next graph, which I'll show it to you. The clinical management of cases, which of course is obvious because we do not want people to die. We do not want people to go on to develop more serious form of the disease. And then we want to prevent the spread of the disease in the community, because that's the thrust of public health. And that's where my work and other people's work is focused on. And we want to maintain essential services. And here, when we talk about, it's not simply the healthcare services, but also the other ancillary services which go along with it. And these have been some of the critical factors in terms of the choices which we made, choices which were made by different nations, and also the politics behind it, because I have never seen any other epidemic in my life where there has been a collision between economic interests and public health goals. This is the first time I've seen it. I came into public health in 1976. My first task was to work with the smallpox eradication program in India with the World Health Organization, and that's what sort of steered me from medicine into public health. And then later on, I worked with the Global Program on AIDS, and I have been watching some of these things in terms of what is different about this. The different is this is the first time where we have artificially created, instead of keeping them as 2 parallel tracks like train tracks, we have artificially created a conflict between economic interests and public health goals. And we want to keep that in mind, because that is what has directed some of the measures which we have taken, some of the measures which other countries have taken, and there are the measures which others have not taken. So it is not only what we do, but it is also what we did not do. Both those things are important when we think about the response. So this is what you see over here is the 4 responses which I mentioned, surveillance and detection. And one of the first things is in terms of surveillance, would be testing. Who is the person who is affected, so that we can make sure that that person is taken care of well, whether it is in terms of the seriousness of the disease, whether it is in terms of medical care, whether it is in terms of public health, in terms of the isolation or quarantine of that particular person. But testing itself has been a problem, as you all know. So the whole response in terms of that key factor of knowing who is infected and where are these people located, at what time they got infected, because we talked about the incubation period, so their propensity to spread the infection, we didn't have that kind of capability. And so did many other countries across the world didn't have that capability. The second one is the clinical management. And this is where that flattening of curve comes along, which is we do not want to overburden our hospitals. We do not want to overburden our ICUs. We don't have the infrastructure. we don't have the equipment, we don't have the health, human capital to take care of them, and how do we handle that? That has been one of the major concerns. So when we hear about this flattening of the curve, the flattening of the curve is to ensure that we are able to bring down the number of new cases so that our impact on the healthcare system is not going to be drastic, not going to be something which we may not be able to meet the need. So that is where that flattening of the curve comes from. And then prevention of the spread in the community. Of course, we want to do that because if we don't do that, then the cases will completely, even while doing that, the cases have been increasing exponentially. So obviously we need to have some way of putting a lid on top of the increasing number of cases. And then one thing which I do want to point out over here is you see this vaccination, and that's what has come about, because this is the outline which was formed as soon as the pandemic was announced in March, early March of, in fact, just about this time in last year. So once this was announced, this was put in place, but now, of course, we have the vaccine, and that changes some of the things in terms of what we are going to be doing. There's also the notion in terms of whether we can prevent this, and there has been different attempts, and one of the things which you know about is the chloroquine trials which have gone on, but haven't been substantially helpful in terms of preventing the disease. Then the essential services continuities, which we are worried about, and then finally, of course, is the recovery. When we talked about the essential services, I mentioned one more ancillary thing. It's not just looking at the healthcare, but we have to look at all other services, whether it is businesses, whether it is the food distribution, whether it is schooling, all those things have to be looked at because, as I said, disease doesn't occur in isolation. So there are two major strategies or sets of strategies. One is the containment. Containment is when the disease is early in the process, when we can actually find out where the little bonfire is going on and then contain that bonfire. So early detection of cases, contact tracing, and confinement of the affected persons, which is that surveillance and detection which we talked about, and for which testing becomes a central focus of it. Of course, we didn't have that facility. If you look at South Korea, if you look at Taiwan, in terms of the initial phase, when the challenges started occurring in February, at that time itself, they were able to put in the containment strategies. So the early successes, when you look at it globally, came from those places which had this containment strategies. Most of the other countries did not have this to the same extent, or in some cases did not have it at all, because the population bigger, or the absence of tests, or the ability of the test to detect the positives, that is how good the test itself is, all those things were worrisome. The mitigation strategies is the alternate one, which is when the horses run out of the barn, we hope that it hasn't gone into the neighbor's home. We are able to contain it in our own barn. That was the idea. So that is where the social distancing, full or partial society lockdowns, which we had here and in many other countries, personal hygiene, which we all practice even now, including the masking, including hand washing, including not touching our mouth, nose, and eyes wherever mucous membrane is present, and environmental hygiene is cleaning up the places. All those things are important, and that's what we are focusing on. Why these things are important? Because these things have been highly variable, and the variability of this is often linked to the economic prosperity of the, and I say economic prosperity in terms of preserving the economic prosperity of those places, and that has been some of the worrying things about this epidemic. At country level, it is very difficult to say what is good or what is bad, because every nation has to determine what is best for that particular nation. You also have heard about the Great Barrington Declaration, which said that, and it is not somebody from the public, it is the people who are very well trained in terms of disease management, economists. They have come together and then issued the Great Barrington Declaration, which is looking at increasing the herd immunity by allowing certain groups of people to experience the disease where the severity of the disease is going to be less. For example, small children. But those are kinds of things which are very difficult. They are not very easily palatable when someone is in political power or when one is in public health, because it is not an easy decision to make for others' children. So what is the impact? So that's why I wanted to have that background before looking at the impact of COVID-19 on the SDGs. So I'm not going to go through all the SDGs, but I'm just going to capture the impact in terms of the first 5 SDG goals. The first one is the no poverty. So you will find on the left of the slide always the goal, and that's the first one is the no poverty. And I'm not going to point out every one of them, but as key things over here. And even before the COVID-19 came along, pre-COVID-19. Now it may be a little bit difficult for us, given that for more than a year that we have been in a different environment, different setting, different mindset. It might be a little difficult, but we were not on track. We are not on track. You can see that 2000 to 2015, the fall in terms of the poverty in the globe, whereas 2015 to 2019, that had really slowed down. On top of it, we are going to have more people in extreme poverty, and they have been pushed into extreme poverty because of this COVID-19. So this is goal 1 is going to be something which is going to have a steeper slope for us to traverse. And that's the same theme which goes on for every one of them. When you go to goal number 2, for example, which is the zero hunger, because I mentioned that these are absolute goals as compared to what we had in the MDGs, Millennium Development Goals, we find that food insecurity was already increasing. You look at 2014 and 2019, there's almost about 3.5% increase in terms of food security. And remember, the population is also going up. So in terms of absolute numbers, it's going up, and it's also going up in terms of the proportion. It is also a threat. The pandemic is an additional threat to the food systems that we're seeing. And this is one of the greatest challenges, especially in developing nations, that it is going to lead to increased stunting and wasting among children. And if that occurs, it correlates very well with, particularly with infectious disease occurrence, whether it is upper respiratory infections or diarrheal diseases, and those things are going to increase under 5 morbidity, that is sickness, and mortality, which is death. So that's something which we're going to be worried about. In terms of economic terms, the small scale food producers are the ones who comprise about 40 to 80%, 85% of all food producers. And if you look at many of the developing countries, in fact, the agri sector, for example, in India, is almost about 2/3 of the economic engine. So in terms of the sector which employs the maximum number of people, 2/3 of it is in the agricultural sector. So the smaller farmers, the smaller manufacturers, the smaller industrialized, the smaller people who own the factories are going to be greatly impacted and are impacted by this particular condition. This is what is the major focus of health people, which is the good health and well-being for all. And when you look at it, you will see over here that the childhood immunization programs in almost about 70 countries, there has been interruption because people have been kept at home or wherever they need to be, so that there's no ability to go out to the healthcare facilities. And similarly, people who used to come home to these homes to provide the immunization have not been able to do that. There's the reversal of the decades of improvement, and this is what I was referring to in the previous slide, and you see that that is even stronger in this particular slide in terms of what is occurring to the under 5 deaths. And we are seeing that other conditions, for example, tropical diseases and already existing diseases and re-emerging diseases like tuberculosis and so on, they will all increase in terms of occurrence because we do not have the ability to take care of those people at this point in time. Our focus has been on COVID-19, sometimes to the exclusion of other ones. When you look at quality education, this is goal number 4. When you look at quality education, over 200 million children will be out of school in 2030, still out of school in 2030. And to give you an indication, school closures kept 90%, and that translates to 1.6 billion children, 1.6 billion children who are out of school. At the peak of this, towards the middle of the last year, 1.6 billion children were out of school at that point in time. And then we have the tech haves and have-nots, which is going to produce major challenges. And the good thing about these challenges is these are fixable. These are fixable. To give you one quick example of that is when you look at, for example, the landlines, there are countries which could not put landlines for telephones and which could move very quickly into cell phones. because all that they needed to do was to set up some cell phone towers as compared to landlines everywhere, the poles which needed to be set up in the rural areas. So the penetration of the Wi-Fi and the penetration of the uh, phones is phenomenal. But the challenge is the continuity of them being able to have the bandwidth or to have it on a regular basis and to be able to use them. And that is why I say that it is an opportunity rather than a challenge as we see it right now. The last one which I want to mention, which is close to my heart, is also gender equality, I did my work in maternal and child health, and I always have believed that if you really want a community to be brought up, you got to do something good for the women. There are a number of studies which have shown that if you give males money, they're going to more likely to spend a good proportion of it on themselves. When you give women the money, they're more likely to spend it on their children. So that's why I said that it's something which is important to bring about this gender equality. But unfortunately, what has occurred is we are seeing an increased violence among women and girls, both in developed nations and developing nations. That's one. And the second thing which we're also seeing is that almost about 2 out of 3 people who are working in the front lines, whether we are looking at nurses, we are looking at techs, whether we are looking at auxiliary nurse midwives, whether we are looking at medical assistants, they happen to be women. And this is across the world. And that is something which is very challenging. And we all know, those of us who are in academics, you read about it in the Chronicle of Higher Education, you read about it in the Inside Higher Education, that women bear the brunt of additional household burdens, and particularly the research and scholarship of women faculty have been adversely affected in developed countries where there are more publications and in developing countries where there are less publications about this, but both are showing that there's temporary stoppage of their ability to do that because their time now is being taken up by other things, particularly taking care of the family. So that brings us to the third segment, is where is the future? What is the future? In the future, we cannot describe unless we look at 2 things. One is something which is fixed, which we already know, which we need to shoot for. That is the SDGs. The SDGs, we know what we need to achieve. We know the targets. The targets are not changing. The SDGs are not moving. We know the timeline. So that's something which is very concrete. But what we do not know is this newcomer into this scenario, which is the COVID-19. So how is COVID-19 going to behave in the future? Is it going to go away very quickly or not? And those are some of the critical questions which we need to pose ourselves. And there are no good answers right now. Answers are slowly emerging. And just like answers are emerging, so are the problems. We already know that new strains have come from United Kingdom, South Africa, and Brazil. This is not to point out the countries from which they have come out. This is mostly to identify the strains which have come out of these places. And now, of course, we know that they're not staying in place. They do not have to show their passport to move from one geographic region to another geographic region. They don't respect borders, and they're now moving around. This is an important notion. There is a tremendous joy and happiness about the vaccines. Every one of us, hopefully, is thinking that we are going to get vaccinated and we are going to be protected. And it is true, because the vaccine efficacy, the 2 vaccines which initially were given emergency use authorization by the FDA are close to 95% effective. We haven't seen those kind of effectiveness of vaccines when many of these recent vaccines. To give you an idea about the flu vaccine, 1 year it was 57% effective, and generally it is about 70%, 65 to 70% effective. So this is something which is amazing. The speed at which these vaccines have been developed is unheard of. But vaccines don't mean vaccination. There is a tremendous difference. The tremendous difference is, one, we are talking about a technology, whether it is a biological technology or it is a medical technology, whichever you want to call it. But the other side is human behavior. So using that technology, when it comes in contact with vaccination, which is a human behavior, there is a big gap. So the numbers are quite important, and we'll I'll show you some data to substantiate what I'm saying. There is vaccine hesitancy, there's anti-vaxxers, and then you also have people who are in the healthcare field who are hesitant about taking vaccines. To give you one example of that, the October 2020 study, which was done by the American Nurses Association, showed that the vaccine hesitancy was among 29% of the practicing nurses. And the major concern was not about the efficacy. The major concern was the speed at which it was developed and the new type of the mRNA vaccine, which has not been used before. And when I mentioned this, it is also necessary for us to take into consideration what the people are thinking about and to allay their fears rather than force more information or medical information or health education information, because that doesn't work. COVID-19 fatigue with its consequences. I don't have to say much about it. The spring break is coming next week. Spring break has already come to some areas of our nation, and similar things are happening at airports. You are seeing it in grocery stores. You are seeing it in many other places. People who have been wearing masks are getting tired. People who are washing hands every now and then, very frequently, as they should be, as we should be, are not doing it because people are getting a little bit tired. And that happens. That happens with any kind of a disease which persists for so long. Regions within nations with mini epidemics. That's perhaps the scenario which is likely to occur, which means that even if nations have been able to put a lid in terms of the increased occurrence of the cases, if we stop the rate of increase, still there'll be pockets of infection where it may still continue that kind of a spread within their communities. And the reasons are obvious, because one is when you look at a nation, the vaccine distribution itself is not going to be uniform unless we are looking at some of the richer nations, some of the nations which have the ability to have the vaccines. And there's one article which I recently came across, which is very instructional. It is from Washington Post. If I recall right, it is February 23rd. Look up the Washington Post, February 23rd, and there's an article about New York City. There are two maps. One shows the cases in the four boroughs, and then the other one shows the vaccine coverage. They don't match. Then there are correlation graphs which show between the vaccine cases and the vaccines. They don't match. Shows between the mortality from COVID, where the place, and vaccine coverage, they don't match. Differential between income by zip code and COVID distribution of the COVID-19 vaccine distribution, they don't match. So that's where this is going to be quite a bit of a challenge. I don't mean that it is going to be in certain countries. It is going to be wherever the vaccine coverage is not sort of a blanket coverage, where there is this potpourri of coverage, it's going to become a problem. And the disease can become endemic. So it may become like influenza, in which case we might require a vaccine to be taken. Booster doses might be necessary especially if we have variant strains, which is what has occurred with the influenza vaccine. Availability of effective treatments and cures might alter the picture. Because when we talked about that the containment in the beginning, the surveillance, detection, and containment, this is something which is very effective in terms of containment, and that might be in the future, but if that occurs, that's certainly going to change the course of the epidemic in each of the nations. And there are a few other additional considerations which we need to look at. The cost of COVID-19 pandemic, and I have a slide to show you what the estimated costs so far have been. The economy of nations, how the COVID-19 has destroyed the economy of the nations, virtually almost every nation for 2020, except for one nation. Vaccine coverage, I'm already alluded to that. The need for global collaboration. And you know what has been happening with the UN agencies, including the United Nations itself and the WHO and so on and so forth. But it is also, there's a global attitude survey, which was done in 2020 by the Pew Research. And there are some very interesting data associated with that. I'll mention it very briefly. We got to look at the equitable distribution of resources. The key is equitable. That is absolutely critical because, as I said, we are in a big boat. We are in a big boat. Some people say that we are in a big sea and then we are in separate boats, but we are in the same sea. My feeling is when it comes to infectious diseases, we are in a big boat. If we are not in a big boat, we wouldn't be talking about it today. As I said, it doesn't believe in hopping from boat to boat. It just comes into a boat and stays over there, the biggest boat it can find. Political will is absolutely essential, not only to tackle this, but also the kind of things which I mentioned about the SDGs. And the critical, helpful thing will be the public-private partnerships. Think about the vaccine development. Think about the speed at which it has been developed. Think about the speed at which it is getting manufactured now, the speed at which it is going to be distributed. All those things, that is the key, the PPP or the public-private partnership. Health in all policies, I'll refer to that. And then it is critical. What this COVID-19 has shown is the big holes in our cheese. I call it the Swiss cheese. We thought it was American cheese. No, we are a big Swiss cheese when it comes to the health system strengthening. Some of the holes are smaller in some nations, some of the holes are bigger in other nations, but every nation seems to have some hole in the cheese. And then how we are going to be prepared for the future pandemics, because this is not the last one which we see. This is the McKinsey report, which shows that for COVID-19, and I've given you the comparative figures in terms of the estimates of how much money has been spent on each one of the previous public health threats which we had faced. And you can see that COVID-19 is in a league of its own. We are talking about T, we are not talking about B. We have gone through all the alphabets in between, including including whatever we can think of in terms of which will give us a better estimate. You can see that it is 18 trillion, and it is an estimate right now. But I also draw your attention to what it is going to cost us in the future as we go along. That's a lot. That's a lot. And the money cannot come from UN agencies. UN agencies don't have this kind of money. This is what I was referring to, is real GDP growth. So you see 3 time periods. The countries are mentioned over here, 2020, 2021, and 2022. So 2021 and 2022 look a little bit rosy right now, and they are good. 2020, look at the impact on the GDP of nations. This is a potpourri of nations you see, but on the world itself, it was a decrease of about 4.2% decline in the real GDP. And the only country which had a positive GDP was China. So every country is going to need, countries which are richer are able to provide that economic stimulus. And many of us are going to be smiling probably next week or this week, or somebody is already smiling because of the stimulus checks. But there are places where people don't have that kind of an ability to do that. That brings us to the next question. If you have the vaccines, how much coverage do we need? And this is again from a different report, from McKinsey. And what they have shown is, this looks a little complicated graph, so let's take a look at it. This is showing on the x-axis is the vaccine coverage. You can see that it increases from 0 to 100% vaccine coverage. This is the population. This is the vaccine efficacy. So the first y-axis which you see is the vaccine efficacy from 0 to 100%. And as I said, the 2 vaccines which were introduced initially, the Moderna and the Pfizer, have a 95% efficacy. So that's why this is pegged over here. The third one, which you see over here, is the range of current assumed natural immunity. Natural immunity is when people are infected naturally and recover from the disease. That's when they have the natural immunity, when the disease causing agent SARS-CoV-2 comes around. So that has been estimated for the United Kingdom, the US, to be somewhere between 5 to 20%. So putting all these pieces together, the efficacy of the vaccine and the coverage which is required and the natural immunity which people have on the basis of what they have already experienced or are likely to experience, then we need about 50 to 60% zero conversion with the vaccine, 50 to 60%. So the total is going to be somewhere around 80% or around that. And that's what Dr. Anthony Fauci has been mentioning, that for this particular disease, we might be requiring 80%. If it is not higher, we at least need about 80%. And that's what this is showing. So who is going to bear the cost of this? How quickly are we going to bring it in? And those are some of the challenges. That's why I pulled this particular slide, is to show that out of the 7.6 billion people, we have covered about 319 million shots. And again, remember, these are shots. These are the number of doses of vaccine which has been given. It is not the people, because you know that with the people, we are going to require 2 doses of the vaccine. So not all of them have received the 2 doses of the vaccine. In the United States, we have given about 93.7 million. whereas globally it is 319 million. About 123 countries have given vaccines, meaning that they're given vaccines. I'm not saying to the entire population, that hasn't occurred anywhere, okay? But they at least have the vaccine to provide to a small proportion of the people, And when SDG goals were signed, it was signed by more than 190 countries. So there are countries which are there which do not have even one single dose of the vaccine. So global collaboration, when we talked about the global collaboration, this is a very interesting a global attitude survey which I was mentioning, is that when you ask older people, the older people are less optimistic about the global collaboration. Whereas the younger people, 18 to 29 years old, for example, in the United States, 67% of them were feeling that we can cooperate with other nations for betterment of all. Whereas older people were a little bit, I don't want to use the term cynical, but a little bit hesitant about this. So the whole survey is available over here. When you get a chance, if you get a chance, please do take a look at it. So finally, the health in all policies is something which is very important, because if we keep health at the center, healthy people are going to be productive. If healthy people are productive, they are going to be contributing to the economy. If the country is doing well, it can maintain a good health infrastructure. So it has got a cascading effect, but we got to keep the people healthy. And that's why I mentioned that there really is no fight between, there's no beef between the economic prospects of a nation and public health. They're together. They're together. So some of the key takeaways are COVID-19 has halted and reversed the progress in several SDGs. I showed you the data. Economic impact and public health are not at crossroads. It's artificial. It's artificial. Health systems, including public health in most nations, need strengthening. Most nations in the world spend less than about $3 out of $100 on public health. We spend little less than 4% of our more than $3 trillion, which we spend every year on healthcare. We spend 3.9% on public health. Health systems, including public health in most nations, need strengthening. I mentioned that. Pandemic preparedness needs concerted resources and actions both nationally and globally. Because of I told you the economic costs, but it is not the economic costs alone. Behind every statistic is actually a person. We cannot forget that. We cannot forget that. Public-private partnerships are critical to future progress towards SDGs. The vaccine story has given us the impetus to pursue this. Economic resources and political will to reach SDGs require urgent attention and action. If we don't do that, by 2030 will remain a dream. And only time will tell whether we as humanity kept our promises to our future generations. Thank you.
Thank you so much, Dr. Sankaran. So much to think about in your presentation. We are currently at 12:45 and we tend to pause at 12:50 if people have to log off to get to another class or meeting. But what I'd like to propose is just that for those of you who have questions, please unmute yourself, pose that question. Dr. Sankaran, if you can stay on the call until perhaps 1 o'clock if there are questions, we'd be grateful. I have to log off myself at 1 for another meeting. But at this point, I'd like to open it up to the audience for questions.
Hi, Gopal. That was a really very informative presentation, and I learned quite a lot. I'm curious, what did China do such that their GDP was on the positive side of that graph? And it looked like the website that you referenced is highly reputable, and I was just wondering if you believe the numbers.
There are a couple of reasons. Thank you for the question. There are a couple of reasons for that. One is China's had the epidemic earlier. That was one major reason. So while we are still continuing with the epidemic in terms of the epidemic curve, they had it much earlier. So they were able to attack that with a much forceful way. The second thing is their system was able to look for, in terms of the testing, in terms of the containment measures, they're much more successful, may not be in terms of the whole nation, but in the place of its origin, they were very successful in terms of concentrating their efforts. I heard a little bit of trepidation in that particular question in terms of how you believe, and that's natural, and that is natural because of the things which have occurred with the particular disease itself, when it was communicated to the WHO, and then the lag time between the actual occurrence of the cases in Wuhan, in Hubei province, and the WHO team going over there, that was several months had expired, and so on and so forth. But even when we take that into consideration, when it comes to keeping the lid on, they have a better ability to do that as compared to other countries because they also have the availability of the vaccine. They have a system, the health infrastructure is in place, and the public health infrastructure is in place to take care of the needs and the demands as they arise. So those are some of the reasons why they have been able to do it, and no other country has really been able to do it to the same extent.
Thank you, Gopal.
Thank you for the question.
Hi, Gopal.
Hi,
How are you?
I'm fine, thank you.
Good. Hi, everybody. I have a question based on some of the research, that Stacy Metz and I have conducted in our region, so a very small part of the world. But I'm really concerned with the part for maintaining our essential services and how we recover out of this. And in our research, what we're finding is that the public health and social work professionals are burnt out from this past year, in addition to everything that was happening before. And some of the reasons for the burnout have to do with more exo and macro system issues, like leadership within their public health agency or social work agency, and at the macro system, the lack of governmental resources. So you oftentimes have an optimistic outlook. So what are your thoughts on how do we get to recover with a sustainable workforce to prepare for the long term and the next whatever comes at us?
That's another great question. It is a great challenge. It's a great challenge because there are two issues over here. One is the mental health issues. The mental health issues of the healthcare workforce. They had been working, and this is the next phase when there is the downtrend in terms of the occurrence of the cases and they have the time to breathe. That is the time when we are going to see that escalation in terms of the mental health issues. And our system has never been, at least in the United States, our system has never been very good in terms of tackling the mental health conditions as it has been for the physical health conditions. So that's going to be a challenge. The second thing is in terms of the number of people who are required. And that has always been a challenge over here. Because when you look at it in terms of any kind of a health services pyramid, the pyramid has to have a large number of people who can quickly be mobilized, who can provide the basic essential services to the population. That is the base of the pyramid. We have sort of a tower, if at all, some people will call it a rectangle, some people will call it an inverted pyramid. We have a lot more people at the top, very few people at the bottom in terms of that. Whether we are looking at, for example, to give you one example of that, is we know that the mortality from this particular condition, COVID-19, has been extremely high in nursing homes and residential facilities. In some places, it has been 38% to 40%. Who takes care of most of the people over there in terms of their healthcare needs and social needs? Certified nurse assistants. What is the attrition rate among them? 60% in a year. So this is not going to be something which it is. I didn't put it over there, but I was thinking about it when Dr. Flam asked me to do this presentation. I said we need a Manhattan Project for this. is nothing short of it. We think of it as a disease. It is not a disease. It is something like a huge hurricane which has come and then devastated. And it takes time to even know what the devastation is. And that is what is going to be not just here in the United States, we are talking about it. That's what it is going to be in many other places which still haven't seen the wrath of the hurricane. So the things which we need to do is look at the workforce in terms of the number, in terms of the type of workforce. We always have been in terms of creating the highest level of people. An example let me provide where it will be useful is when the Affordable Care Act came along in March of it's again in March, a lot of things happened in March, March of 2010, when Affordable Care Act came along, we created the navigators, community health navigators. And the community health navigators come from the community. They don't need to have a degree per se, but they need to have the nuance to navigate the system, a good GPS in their brain to navigate the labyrinths of the healthcare system. That's the kind of thing which we need to create now. Just like we are now doing with, for example, contact tracing. We are training people in a period of 6 weeks. We are saying that, hey, free training is available. Come and do that. That's the kind of thing which we need to have, but which has got some permanence in it. Did I answer your question?
Yeah, thank you very much.
Thank you very much, Gopal. It's great to hear your presentation. So my question, I have a fundamental question about the UN Sustainable Development Goals. So given that nation states are where the major political decisions and policy decisions are made, what's the mechanism for promoting these goals throughout the world? And my second question is not as basic to that. It's so what are your ideas for moving forward in future pandemics to make sure that people realize that the economics and the health concerns are not at odds with each other?
Great questions again. The first one, there's a very simple answer. Very difficult to attain, but it's called people power. We always have shifted aid, for example. You hear about, let me give you two examples, quick examples. One is vaccine diplomacy. You hear that about China, you hear that about India right now, vaccine diplomacy, where you give vaccines, oftentimes you give free of cost to nations, right? Vaccine diplomacy. Now, the thing which we don't see is who is getting those vaccines in those nations? Are those the most vulnerable people who are at greatest risk for contracting the disease, in the severe form of the disease and dying from the disease? Are those the people getting the first dose of the vaccine when it comes from overseas? If it is not, then the same system will continue. So unless there is some kind of a grassroots movement to take away some of the power which we people have given, we people globally, I'm talking about, globally, every country, as every sovereign nation has given to the leaders, there has to be accountability and transparency. Without that accountability and transparency, none of these things, the old form of giving aid is not going to work any longer. Okay? Even with Millennium Development Goals, they're partially reached. They're partially reached because the aid was coming over there, but then there were people who were taking a small slice of the aid. So when finally it reached the people for whom the aid was meant, there was not much left. So that's the first question. The second question is, we need to have an early warning system in place. If hurricane is going to come, we need to know, not that day, we need to know as far as early as possible so that we can mobilize. We can mobilize the resources. When I say mobilize the resources, mobilize the personnel, mobilize the infrastructure, mobilize the equipment, mobilize what we need to distribute, whether it is food, whether it is whatever it might be, we need to. And that requires the cooperation of the economists, cooperation of the people in the health sector. How much is it going to cost? What is the most efficient way of distributing it? Those come from the economists. Those come from the models which they can create. How do you do it? How do you develop the trust of the community? How do you build on the trust of that community? Those come from the health sector. So that's why I don't see them as going in two divergent directions. If at all, I see them, even if they don't want to handshake, they are the two tracks of a railroad. They are going in the same direction. They're not separate. So I'm not giving you the full answer, but I'm saying is that the fundamental paradigm in which we have been viewing the world, whether it is pandemic control, whether it is in terms of donor aid, whether it is in terms of benefiting the people on the ground, I think that has to change. If we don't change it, things are not going to change. Let me give you one quick other example. When you look at Healthy People 2000, that is the blueprint for our nation, Healthy People, which is the federal government puts in conjunction with taking into consideration the states, taking into consideration what the people are asking for, okay, and then the blueprint. One of the goals in that was to reduce health disparities. There were 3 goals. One of them was health. 2010 goal was eliminate the health disparities. First time I read it, I dropped what I was reading out from. Eliminate health disparities in a decade, 2010 to 2020. That's not going to occur. So the point I'm making is sometimes we have to be realistic in terms of, are we really meaning to achieve those goals? Or those goals are aspirational, those are good visual things, goals are universal. Everybody, all those nations coming together and signing the SDGs in 2015 in preparation of this laying down of the SDGs is great. But what is the accountability each nation is bringing to the table at that point in time and thereafter? Why are we in 2020? I gave you the example of 5 of these SDGs. Why is it that there is not greater joy in terms of realization of them? I think those are fundamental questions we need to address. And then my belief is it will get addressed because the generation of the younger people we are seeing now, I think they are much, much more tuned to the social aspects and to the social justice, health equity, not just health equity, economic equity, social equity, and also to human rights. I see that mindset to be a phenomenal mindset which will bring all these pieces together.
That's beautiful. That's a good last takeaway, I think.
Yeah, it looks like we just hit 1 o'clock, everybody. Thank you so much again. This was a fantastic presentation. I really enjoyed it. I think I'll have to go back and rewatch some of it and listen to the recording later.
Yep, and I'll be posting that on Digital Commons, right,
Yeah.
Amy?
That's right. I'll get you the link as soon as it's ready.
Okay,
Thank you all
sounds good.
so much. Thank you for the opportunity. And thank you, Amy, for all your help. Thank you. Greatly appreciate it. And have a
Absolutely.
good rest of the day.
Thank
Thank
you.
you, Gopal.
too.
Always learn a lot from you.
Bye, everybody.
Bye-bye.
Bye.